to the Thursday CME of South Delhi Pediatric Study Group. The topic for today is MISC and post-COVID syndrome. I would request the chairperson for today's session is Dr. Khandelwal. Dr. Khandelwal is a senior pediatrician in South Delhi. I request sir to kindly moderate the session and introduce the speaker.
Thank you, Dr. Circle. It's an honor to preside over this session. The speaker for today is Dr. Amieleena Chhabra. She is a consultant pediatric rheumatologist at Sitaram Bhartiya Hospital, Rainbow Children's Hospital, and Fortis Memorial Research Institute in Gurgaon. She has trained in pediatric rheumatology and immunology from BC Children's Hospital, University of British Columbia, Vancouver, Canada, and further specialized in autoinflammatory diseases from Harvard Medical School, Boston, and Hospital for Sick Kids in Toronto, Canada. She is a certified pediatric rheumatologist by European League Against Rheumatism. She has a number of publications to her credit and is actively involved in translational research with centers across North America. We heard her yesterday discussing with Dr. Vikas, and we expect some very good discussions today. Over to you, Dr. Amieleena.
Thank you, sir, for the lovely introduction. And thank you, South Delhi IIP, for having me today. And I'm just going to try to share my slides before I start talking. Just taking a little longer than I expected. Just a second. Okay, it's asking me to.
We can see your screen, ma'am.
Is that visible? Is that visible?
That's
Vikram?
visible. That's
Okay.
visible, but I think you are not doing it. Slideshow mode में एक बार कर दीजिए इसे. The whole screen is visible.
Oh, okay.
The way you are seeing it here. We can see your desktop and the screen.
Ab dikh raha? Yeah, that's good. All right. Sorry about this. Just took a little longer than I expected. Okay. So I know there's lots that's been going on in terms of COVID everywhere. And there are a lot of confusion about different words and stuff that is going on in terms of the different presentations. So today we're going to talk about two different topics. One is multisystem inflammatory syndrome in children, and the other is post-COVID syndrome. So what we know about COVID and its presentation from the time it was initially recognized in December 2019, that our evolution of understanding of COVID over the time has changed dramatically. in the initial offset, we were thinking that it was more of a benign disease in children with minimal effect, and most of the time thinking that kids were predominantly immune to it. By spring of 2020, we started seeing certain presentations, specifically initially from Bergamo in Italy and then the UK, where they had higher COVID numbers in adults, that kids had started presenting with a post-infective hyperinflammatory syndrome, predominantly 2 to 4 weeks after the initial presentation. And this is what is known as multisystem inflammatory syndrome in children, which is associated with COVID. Furthermore, over the time with increasing numbers, we have also realized that kids can have acute COVID infection. And in that case, it is something similar to what we see in adults, and the inflammation is more of a hyperinflammation associated with acute COVID and more of a cytokine storm. By the time it was October, November 2020, we also started seeing that there are presentations like post-inflammatory syndromes, in the form that you have symptoms persisting beyond the infection and lasting up to 4 to 6 weeks or even up to 6 months. And that is what is known as the post-COVID syndrome or long COVID syndrome. So today we're going to talk about 2 predominant presentations: the multisystem inflammatory syndrome, which is a post-infective hyperinflammation, and long COVID or post-COVID syndrome, which is like a presentation persisting or even having new symptoms after the acute presentation. In the past, you have been hearing about the acute presentation, which was taken by Dr. Gupta last week. And we did talk about the cardiac manifestations predominantly of MISC yesterday, which was very clearly and nicely presented by Dr. Kohli. Today, we're going to talk about the 2 other topics which we've been seeing in children, the MISC and post-COVID syndrome. So in terms of what is MISC, and if you start looking at the different papers that are being published, there's a lot of confusion in terms of the nomenclature and what it exactly is. So CDC and WHO have named it as multisystem inflammatory syndrome in children, which is associated with COVID-19, known as MISC. And I would be using this word for the rest of the talk for ease and understanding. The European Union came up with the name as PIMS-TS, which is pediatric inflammatory syndrome, multisystem syndrome temporarily associated with SARS-CoV-2 infection. Now, the UK had obviously to do something different than what the rest of the European Union is doing. So they named it a little differently and called it pediatric multisystem inflammatory syndrome, which is temporarily associated with COVID-19. So they don't say SARS-CoV-2, they say COVID-19. Kuch to alag karna tha. So that's where it is. And then in October of 2020, people started seeing the multisystem inflammatory syndrome in adults as well. And that is when it was recognized that it's not only the kids where the immune system is playing this role and we're getting a response much later, it's also being seen in adults as well. So it's the 2 different presentations that we are talking about: the acute presentation, more for the cytokine storm presentation, and then the post-infective hyperinflammation that we are seeing in kids. And then, so this is how it was first reported. The first reports were from Italy and UK, and predominantly the presentation can vary in MISC, and we'll be talking about the diagnostic criteria eventually. But what we need to understand is that the main systems that are involved include the presence of fever, which is persistent. Along with that, there can be the gastrointestinal symptoms, there can be mucocutaneous symptoms, there can be neurological symptoms, cardiac signs and symptoms, and elevated inflammatory markers. So fever with any of these systems involvement, raised inflammatory markers, and history of contact or positivity in the past should raise the suspicion of MISC. So the CDC, WHO, and the Royal College in the UK came up with different definitions. And if you see them, it's predominantly talking about different age groups in children, but yeah, less than 21 is predominantly what CDC talks about, and that's where most of the published data would have kids 21 and younger. Most of the studies from the UK, from the US would be talking about that age group. So it's persistence fever with different categories in all three groups. I like the WHO definition for people who don't exactly know what's going on, because it is much more elaborative in terms of its clinical symptoms. The CDC and the Royal College definition talks about single or multi-organ dysfunctions. Instead, the WHO has a more elaborative definition in terms of symptoms, where it talks about what all you need to be looking at. So things like rash, conjunctivitis, mucocutaneous inflammations. They talk about presentation with shock, cardiac involvement, coagulopathy, and acute GI symptoms. So if one doesn't really know what is MISC and what are we talking about, I think the WHO definition is more elaborative and easier to understand. And then, of course, along with that, we're looking at markers of inflammation, which are predominantly high. The CDC definition talks about more elaborate workup in terms of what all you're looking at, while the others talk about the general inflammation rise as it is. And then you would have to have association of COVID, either in the form of a positive RT-PCR, serology, or exposure within the last 4 weeks. And of course, we have to rule out all infections as the exclusion diagnosis. So one of the largest studies that we know of from North America is from New York, where they started seeing much higher numbers at the time of their acute presentation. So last April, May is when you would see that they had much higher numbers of acute COVID, and then they started seeing a higher surge of MISC. So I just brought out this study to make you understand, and this table depicts it quite well, that the surge of MISC comes after around 4 weeks of the surge of COVID, acute COVID infection. And that is something that we've been seeing in India as well. If you remember last spring, March, April 2020, the higher numbers were in Maharashtra, and probably our first case reports of MISC started pouring in from Pune and Bombay because of the fact that they were seeing acute infections much earlier. By the time we had higher numbers in Delhi, so we're looking at April, May, June, that's when we started seeing fewer for MISCs. So whenever there's an acute surge of COVID, you would expect another 3 to 4 weeks lag time before you start seeing a surge in MISCs. And I'm presuming the way we are seeing the acute numbers now, we would be seeing a higher surge of MISC also in the next few weeks to come. So I'm going to just talk about a couple of cases to give a general idea of how they can really present. So there was this 11-year-old male with mild history of asthma. He was just using salbutamol as and when needed kind, not on regular treatment. And he presented with 4 days of fever, along with fatigue and lethargy for 4 days, and decreased oral intake. He also had vomiting and diarrhea. There were no respiratory symptoms. There was no rash. On physical examination, he was tachycardic, he was hypotensive, there was dire mucous membranes, normal conjunctiva, no rash, soft abdomen, and a decreased capillary refill time. In the ER, he received high flow oxygen, IV fluid resuscitation, started on antibiotics. They even started the dopamine there, and then he was transferred to the ICU. In terms of his labs, you would see that he had severely high inflammatory markers, high procalcitonin, ferritin, CRP more than 300, high BNPs, D-dimers. Even liver was mildly affected, and he had a positive serology to COVID with cultures which were negative. So this kid had a long PICU stay, but please note, at the time of admission into the ICU, he had a normal echo. However, required vasopressors for a long time, around 6 days. He was continued with IV antibiotics. Was also started on enoxaparin prophylaxis, considering that his D-dimers were super high. He received respiratory support as well. But over the time, his inflammatory markers and the cardiac biomarkers trended up in spite of all the treatment that he was receiving. And then a repeat echo was done, which was suggestive of aneurysms. So even though he had normal echo at the time of admission, a repeat echo did reveal that there were aneurysms in him at that time. So he was treated with IVIG and methylprednisolone at a pulse for 1 day, and then further tapered on to oral and further tapering. And then the second case is a 4-year-old male who presented with fever for 4 days and a new onset rash. He also had abdominal pain, had a SARS RT-PCR done, which was negative, but there was history of COVID-19 in a family member about a month ago. He did not have any respiratory symptoms. On exam, had tachycardia, but was a non-toxic appearing child with no conjunctivitis, some lymphadenopathy, and a macular rash on chest, hands, and feet. Abdomen was soft and he had normal perfusion. He was not hypotensive. So this kid did not go to the ICU, but was admitted in the ward. His lab work again showed high neutrophil counts, high inflammatory markers, and when a Povic serology was done, that was also positive. His other organ system involvement wasn't there, like his liver and kidneys were normal. So this kid, he continued to have fever and rash the next day as well. He had an echo which was done, which is suggestive of a trivial pericardial effusion, and his coronaries were normal. However, his cardiac markers trended up, and he received methylprednisolone and IVIG, following which his fever resolved, there was no abdominal pain, and so did the rash. And he was discharged home on aspirin and prednisolone taper. But of course, follow-ups on the echoes, which I would, again, re-emphasize about in the next few slides, and Dr. Kohli has talked about it yesterday as well. So what do we know about seeing these few cases? That what we need to understand with MISC is that cases with clinical shock and cardiac dysfunction, they improve very early when you institute methylprednisolone. So predominantly, methylpred has become a savior for most of us in the last 1 year. Over the time, it's always been more on in terms of what we think, and a general practice is infective, and steroids are an absolute no-no. But I think over the year, we have realized that many a time this is more of a lifesaver for many conditions in comparison to our older thought and worry that steroids in case of infection is going to be a big problem. Also, one needs to understand that COVID-19, along with the way it is in MISC, the way it is presenting, we should also consider the other commoner presentations like bacterial sepsis and macrophage activation or HLH, which present in a similar way. And then we definitely need standardized protocols in terms of echocardiographies, even at the time of admission, during the hospital stay, and then at post-discharge follow-ups as well. And we should be trending the inflammatory markers over the time in the hospital as well as after during the recovery phase. So the common thoughts that would come to you when you see a MISC is, what is this presentation similar to? Like the common thing that you would think of when kids present to you, if this was not the COVID time and scenario, would be conditions like Kawasaki disease, Kawasaki shock syndrome, staphylococcal or streptococcal toxic shock syndrome, macrophage activation or HLH, hemorrhagic shock, and encephalopathy syndromes, because many of them would present with subtle neurological manifestations as well. And the less common stuff, which are one of our favorites, like vasculitis and SLE. So the different criteria for hospitalization when you see a kid with similar presentation would be if they have abnormal vital signs, respiratory distress of any severity, neurological deficits. Even if there are slight subtle changes in mentation, he should be admitted. If there's any evidence of other organ damage like renal or hepatic injury, markedly elevated inflammatory markers, abnormal cardiac markers like BNP, TROP-T, ECGs, any child with shock, any child with dehydration or hypovolemia, and features of KD should be hospitalized. And then now that we're talking about this, even kids who fulfill criteria of KD should be reported as MISC if they have any evidence of the same. And CDC and Royal College says that any death, pediatric death, one should consider MISC if there is evidence of SARS infection around. So I'm sure we also miss, and it's world over, we're all missing some of the MISCs. So, and then the bigger talk that has been happening is, and we talked about KD yesterday as well, is that many of them present as KD. So initially when we started talking about MISC, it was like, oh, it's KD happening, but it's KD secondary to COVID. But over the time, there have been certain studies and there has been data collected in the last year, which shows that there are certain changes or differences between how MISC and KD is presenting. So data from North America and the UK shows that there is a vast ethnic or racial difference. What we know of in terms of KD, that it is a disease which is highly predominant in the Asian population, predominantly Japanese and Chinese population, even the other Southeast Asians. But any Japanese child presenting with fever and a rash in North America, and that age group less than 5 years, you would think of KD until ruled out otherwise. But while in MISC data that has been collected till date, in North America, it's predominantly more the Hispanics, the Latins, as well as the Hispanic Blacks who have a higher number, and there are much lesser number of Asians that have been reported. While UK is still collecting their data, and that's not published yet, but from what we know from different case series in London, it's the Asian population and Southeast Asian predominantly. It's not the Japanese population, it's predominantly Indians, Pakistani, and Bangladeshis who are presenting with MISC there. So it's still evolving. We still have to see what we are talking about in terms of the ethnicity part. However, in terms of age and presentation, what we've seen with MISC is that it predominantly it is in the older age group, with the mean age being seen around 8 years. However, it's practically across all age groups in children, with the youngest being reported is at 3 months to the oldest at 17. While if you see KD predominantly presents in children less than 5 years of age, that's the common predilection. Of course, I mean, people would say we've seen KD at 11 years or 13 years. Agreed, yes, we could have it, but the predominant common group is less than 5. Then what we are also seeing is the way they're presenting. So MISC-associated presentations have more of GI and neurological symptoms. I mean, it's not that KD cannot present with that, but it's much lesser seen. And there's more of cardiac dysfunction seen in MISC in comparison to what we see in many of the KD kids. The other thing that has been noted is, do we see if there's an incidence difference in coronary artery aneurysms? That is not really known if they between MISC or KD. However, what has been seen that more of shock and more of left ventricular dysfunction is seen in case of MISC. In terms of the lab presentations, kids with MISC would have lower platelet counts, lower absolute lymphocyte counts, and much higher CRPs. And this is something that we know from only few studies that have been published yet. Of course, we are still learning in terms of the presentations. So as we were talking about the predilection, and that's how that has been beautifully depicted in this study again from New York. And you would see this is their ethnic differences in terms of much higher numbers in Hispanics and Hispanic Blacks, while Asians are much lesser here. And they have also shown their mean age group, where you would see the predominant age group being 5 to 9 with the median of 8 years. So coming to the diagnostic criteria, which has been basically come up by the American College of Rheumatology's guidelines, and we're talking about how and what one needs to think about. So if there is fever which is lasting for more than 3 days, and there is linked to SARS-CoV, but at least 2 of the presentations, so predominantly rash or GI symptoms, edema, oral changes, cutaneous changes, conjunctivitis, lymphadenopathy, or even neurological changes, one should start looking into further workup for MISC. And then they have talked about the tier 1 screening and then tier 2 screenings. And I'm not going to read the entire details of this. This is freely available, and we can get it, and you don't need any subscriptions for accessing this article. And then in terms of the treatment, it's again a well-defined algorithm in terms of what needs to be done. And the main line of treatment that we are looking into is that every child who's presenting with MISC, depending on if it is mild, moderate, or severe, would be getting methylprednisolone and IVIG. But the methylprednisolone tapers and durations are different. If it's a mild disease, you're dealing with oral steroids and you're tapering it over 2 to 3 weeks. While if it's a moderate one, you're looking into pulsing maybe for 1 day, continuing to high dose oral steroids, and taper at a longer period of 6 to 8 weeks. Well, if it's a severe disease, we're looking at pulses at 30 milligram per kg, which is pulse methylprednisolone, along with for 3 days, and then going down to a high dose of oral steroids, and taper would depend on how the child predominantly behaves over the time. Considering the fact we're talking about immunomodulators also other than these two, and North America, because IL-1 blockers are very commonly available, they include anakinra in their refractory or resistant disease. However, in our setup, since we do not have IL-1 blockers available, we would be considering tocilizumab, which is the IL-6 blocker, if we need to. The cardiac management that has been outlined, and this was discussed in detail yesterday, so I will not go into that, and I've just put in just one slide now to talk about it and emphasize on the importance which Dr. Kohli had talked about even yesterday. That is, we are going to be following up the cardiac markers, we're going to be following up with EKGs, we need to do echoes on follow-up during hospital stay and discharge, and the ACR criteria also talks about cardiac MRIs at 2 to 6 months, but I don't know how practical that is in terms of our settings. But of course, an echo is easily doable. The cardiac markers are easily doable. So we should not resist from doing these for our patients. In terms of the immunomodulatory treatment, which I just spoke about in terms of what we need to do in the initial presentation of IVIG and steroids, I wanted to talk about the other modulators which are available. As most of the reports that you would see or the guidelines would talk about IL-1 blockers, which we were talking about. Unfortunately, we do not have the IL-1 blockers in India. So our next line of treatment, if we do require it in case of resistant MISCs, is IL-6 blocker tocilizumab. UK has used infliximab also in their initial case reports, and there has been a good response. So if we do not get toci, considering the fact that the numbers are crazy, we can consider infliximab. And of course, if none of these are available and they are expensive drugs, they are many times we would have patients who can't afford them, do rely on high-dose steroid for longer time. It can be given for 3 to 5 days if things are not going the best and there is no response in the initial IVIG. Also consider a second dose of IVIG with high-dose steroids if we do not have other immunomodulators in hand. There is also consideration of antiplatelets and anticoagulation in MISC, and that's something that we have been doing in KD as well. And based on our experience about these conditions, and specifically with KD, where we know that myocarditis is the predominant feature, and there is emerging data from what we know from the adult studies that is predominantly seen in COVID as well, along with the fact that there are case reports in children where we have seen pulmonary thrombosis and DVT. The recommendation are to start them on low-dose steroids. Also consider enoxaparin if you have very low cardiac function in the form of ejection fraction with less than 35%, and consider continuing them until you have normal platelets and coronaries, which is similar to what we do in terms of KD guidelines. And the important part is that one needs to make sure that you're avoiding or not giving them if there is persistence of thrombocytopenia, which we are seeing in MISC in comparison much more than what we generally see in KD, until unless KD is presenting with MAS features. So then it's a different thing. But it is much more predominantly common in case of MISC. So if you have a thrombocytopenia, do not put the child on aspirin and send them home. If you have very large coronaries, consider adding an anticoagulation therapy and not just aspirin. Considering the fact that we are looking into a higher number of acute COVID-19 infections as well now in children, which we initially thought, this is not happening. We're just looking at hyperinflammation, which is post-infective. But now there are reports where you also have much higher numbers with acute COVID presentation as well. So the differences that we've seen in terms of how they present, the acute ones would also have, may not have a prior exposure, but MISC would obviously give you a prior exposure of the virus. The MISCs are less likely to have comorbidities. The kids with acute COVID infection and the cytokine storm like hyperinflation picture may have associated comorbidities. So most of your kids with chronic diseases, if you are seeing them having acute COVID infection, consider that they could go into the cytokine storm and have hyperinflammation of that pathway. Then the features of typical Kawasaki, if they're there, that points more towards MISC than acute COVID infection. Again, MISC will have more of GI symptoms, so predominantly abdominal pain. There have been case reports that kids have also had open laparotomies because of acute abdominal pain. They initially thought it was more of a pediatric surgical acute emergency, but eventually turned out to be MISC. So abdominal pain in our scenario these days, one has to think about MISC in the initial offset of presentation as well. Then the acute infection, of course, would have more of core respiratory symptoms. Again, the MISC patients present and develop quick shock much faster and also have features similar to MAS, while the ones with acute infection have more of a cytokine storm-like picture. You will have much higher cardiac markers in case of MISC. Echoes will show much more coronary abnormalities than MISC, while in case of the acute infection, it will be more of myocarditis and left ventricular dysfunction. While MISCs, they have a great response to IVIG and glucocorticoids, and that should not be delayed and initiated as soon as possible. In terms of the hospital stay, we've seen the mean duration of stay is much smaller or shorter in case of MISC, around 5 days, while kids with acute COVID infection are staying much longer, around 10 to 12 days in the hospital. And in case of the cytokine storm or acute infection cases, you would consider steroids. They talk about anakinra again because it's one of their favorites, a good drug, but unfortunately we don't have it. We could consider tocilizumab, but do consider the high risk of infection as well when you're going into that setting. So what we know in terms of the experience with MISC, the problem or challenges that we face in the ER or when the kid comes to us in the OPD is, what do we do with the mild MISC symptoms? So there is no shock, the child is not sick, he's not a toxic looking child. What do we generally do? Do we look into follow-ups? Yes, we definitely would be doing that. Are we doing lab work in those kids? Yes, we would be considering doing that and follow up. And do we do a cardiology referral? Yes, I would say, yeah, we do a baseline echocardiography because over the time we've seen that many kids may not have it at presentation, but over the time would develop aneurysms. And so cardiac follow-up is of utmost importance. So this is, I just took this from one of the papers where it talks about what are the predominant treatments that have been given to kids with MISC, and you would see most of the kids with cardiovascular involvement or full-time Kawasaki presentation have all received IVIG, so 75 to 80, 100% of those kids have received that. Corticosteroid, again, at a much higher number of 50 to 75% of kids receiving it. Vasopressor support, again, in the 55 to 75% patients are receiving that. Immunomodulators are much lesser, like less than 25% have received those. Intubations is quite variable in terms of what kind it is presenting with, and very few have required ECMO, but yes, that's another option moving forward in the sick kids. And now I'm going to just talk briefly about post-COVID syndrome. In many literatures and publications, you would also see it called as long COVID syndrome. And these are the signs and symptoms that develop during follow-up or after the infections have settled in. We do not have too much in terms of the pediatric age group data in the long COVID or post-COVID syndromes, but what we know from the adult publication is something that I thought I'll just talk about in brief. So if you see, it's a little confusing and difficult to define because many of the acute presentations and things like post-hospitalized complications are also coming into that time frame where you would consider that to be part of the long COVID or post-COVID syndrome. So it's an overlap of the long COVID symptoms that come in after 4 to 6 weeks of the initial onset of acute infection. We also have the group where you have MISCs and later time presentations, also associated hospitalization complications. So it's a broader category, and it sometimes gets difficult in terms of what are we defining it. So one of the present definitions that we talk about is persistent severe fatigue, headache, and brain fog. So mild subjective cognitive impairment. And there's a lot of talk about brain fog in the adult population who've had COVID. More than 4 weeks after the acute illness, and is independent of the acute illness severity completely, is what is long COVID. So predominantly 3 systems that people have seen: respiratory, neurological, and cardiac in terms of post-COVID. But there was this study where they have followed up 1,733 patients and see that 3/4 of the patients who were hospitalized had at least one ongoing symptom at 6 months after their acute illness. Also, people have noted that 1 in 5 patients not requiring even oxygen during hospitalization had decreased lung function at 6 months. So even though you may not have an acute presentation where you require intensive treatment and therapy, lung functions are being compromised even in mild cases. And then there are a few studies around Europe, predominantly noting in France, Switzerland, and they have seen that there around 50% of patients who had mild acute COVID had persistent symptoms even at 2 to 4 months. And then 50 to 75% of patients reported new symptoms which were not present at the time of the acute presentation or had reappearance of symptoms that had resolved. And 9% reported severe prolonged symptoms as well. So we're going to start seeing these as coming in too with the number of acute cases that we are seeing. And then this study talks about how 1/4 of patients who develop new neurological symptoms after the acute COVID and require hospitalizations as well. So we're seeing a lot of neurological symptoms coming in, and there is a lot of data coming out of North America now with a lot of these presentations as well. So what are we talking about? And I just tried to summarize from all the different papers that I could go through, that these are the group of symptoms that they're predominantly seeing, and they're lasting up to 4 to 6 months as well. So you would have respiratory symptoms, there's ongoing fatigue. Many rheumatologists around the world are seeing a lot of fibromyalgia post-COVID. There are sleep disturbances, anxiety, depression, neurological dysfunctions, and musculoskeletal symptoms. So reactive arthritis, fibromyalgia, again, vague abdominal musculoskeletal pains with no specific arthritis is also being noted. In terms of, and since there's so much talk about brain fog and neurological symptoms, I thought I'll just get in a little bit about what this is. And this is the most common neurological symptom seen in case of post-COVID syndrome, and presents with short-term memory loss, concentration difficulty, word finding difficulty, speech difficulties, which adults predominantly are noting. And there is no clear correlation with the severity of COVID infection, age, or comorbidity. So even people with mild symptoms are complaining of things like brain fog. And symptoms can be fluctuating. They can be good and bad days. And there's also associated with symptoms like fatigue and dysautonomias. A lot of sleep disturbances also noted, a lot of mood disturbances, people experiencing anxiety and depression post the syndrome. As it is, if you can see, even in today's scenario, we are seeing a lot of panic setting in. So these are things that may persist further on. The other thing that you see in the neurological symptoms is a lot of headaches, paresthesias, and dysautonomia. And these could go hand in hand with all the anxiety and depression that people have, or post-trauma syndrome correlation as well. And many times patients may have multiple chief complaints, and it's difficult to have someone coming with only one as a symptom. And then I found this where you would see what they have seen in terms of neuroimaging in these patients with neurological manifestations. And they have not seen large inflammatory vessels or lacunar strokes in patients presenting with neurological symptoms. But what they're seeing is there are microvascular white matter changes that have been reported. And there is increased severity in patients who have a higher age. There's more in terms of vascular risk factors if they're involved. Patients who are having migraine are also seeing more of this. But again, this is a learning curve. We are still seeing more and more of it, and there's more that will come out of it. There's not much, then hardly any studies. There are just few case reports that have been reported in terms of post-COVID syndrome or long COVID syndrome in the pediatric age group. What we are seeing is post-infective reactive arthritis. This is presenting a little differently than what our usual reactive arthritis do, with more of small joint involvement. Predominantly our textbook teaching in terms of reactive arthritis is large joints, single joint involved. We don't see generally inflammation of the small joints of the hands, like PIPs, DIPs. What we are seeing in these kids is predominantly small joint involvement. Multiple joints are involved. They definitely have a good response to anti-inflammatories. The antibody profiles are all negative. We haven't seen any eye involvement as part of the post-COVID reactive arthritis group in children, which is a common feature in case of the other ones, or the common, what we used to call as Reiter syndrome, which of course is an outdated term, but did have a lot of eye involvement, which is not yet reported in the post-reactive arthritis secondary to COVID. And the other thing that we are seeing is a lot of Raynaud's phenomena. So new onset Raynaud, people who've not had autonomic instability in the past, never had Raynaud's as a presenting feature. That is something that we are seeing in the post-COVID or long COVID syndrome cases in children, where you see the onset occurring around 4 to 6 weeks after the acute symptoms, or even exposure to an infected person. And this requires more than usual the avoidance of temperature variations. So that's the main key when we talk about treatment of Raynaud's, is not only extreme exposure to cold, but the fact that if you're seeing too much of temperature fluctuations, that also triggers a Raynaud's phenomena. So they are even much more sensitive to that than the usual Raynaud's, and they are responding to topical and systemic vasodilators. It's not an extreme presentation in terms of where you would see ulcerations yet, but you never know. It's something that we're still exploring and would know more about in the future. So yeah, that's a brief about MISC and post-COVID syndrome, and I am open to any questions.
Thank you, Dr. Amieleena, for a wonderful presentation.
Yes, sir.
Before I take the questions which have come up, I want to ask from you that you mentioned that we can see a surge of MIC cases, MIC cases after this COVID, after about 4 weeks. Now, for a general pediatrician, what should he look for? What signs or what investigation should he do so as to know that this patient may be going into MISC? So,
no, depending on how they are presenting, that's what the thing is. There are two different groups that we are looking into. So ones which are like sick, acute, hypotensive, that group, which would require extensive ICU care and methylprednisolone in pulses and IVIG treatment. What may be in the OPD, what we would be seeing are the milder cases. So either kids with typical KD symptoms or incomplete KD symptoms. So fever with rash, with mucopurulent symptoms, edema of the hands, with conjunctivitis. If it's a typical KD picture, yes, these could be MISC, and we need to be treating them as that first. In case of milder symptoms, and even in those which have incomplete Kawasaki-like presentation, depending on how sick, if it's a non-toxic looking child who doesn't require admission, I would say more frequent follow-ups. Probably you're seeing them again in about 2 days, trending on the labs, probably a baseline echo, and regular, more frequent follow-ups in those kids. The ones which are sick, of course, they go to the ICU, they require much more different sort of treatment. The other thing that is commonly seen is severe abdominal pain as a presentation. So all those kids where you have severe abdominal pain, considering an acute abdominal-like presentation, in those kids also we need to be considering MISC. And those are the ones which were initially missed in the UK as well. They were kids who ended up being in the pediatric surgery division and ended up even having laparotomies. I think that it was appendicitis or an acute abdomen. So those are the kids, and we have seen such presentations even in Delhi in the initial time when we had a higher surge. So I believe that we would be seeing those presentations again coming in with the acute numbers going down and then having the post-inflammatory symptoms coming in.
Now, taking the questions, Dr. Kohli has asked, can acute COVID-19 have rash?
Acute COVID-19? No, sir, I don't think we've seen that yet. That's what I remember at the top of my head. No, I don't think we've seen rash with acute COVID yet. Though I would go back to it again and see if there is something that I'm missing.
Once MISC is setting in, you expect rash to be there?
Not all of them. Not all of them. But see, if you're getting a typical KD picture with rash, fever, abdominal lymphadenopathy, non-purulent conjunctivitis, and in this scenario, I think every KD should be considered a MISC at this moment, until proven otherwise. And again, considering the fact that KD and MISC would have a similar treatment pattern, depending on what they're, if it's a typical KD, you're going to be treating him with IVIG for sure. The only thing is, are we doing steroids in them or not? Considering the fact that we are more in the pandemic, probably yes, it may be worthwhile to even give a suspected KD with no definite association with MISC with steroids. I think I would do that. At this time, if you feel that the patient is not coming with a history saying there's no exposure, हमने तो देखा ही नहीं अभी तक, हुआ ही नहीं किसी को, घर में सब ठीक है, इसी को हुआ है सिर्फ, and there are people who would come and tell you this, and you're seeing that KD picture. And kid is, I would say, yes, treat him with oral steroids. We do treat them with oral steroids even in resistant KD. So why not at this stage with MISC? And the way things are going and we're not able to get our serologies, the RT-PCRs are getting, like people are overburdened, we may not have answers with that. So probably treating them would be the best way moving forward at this time.
Dr. Neeraj Avasthi has asked, when do we consider steroids in acute COVID-19? Are there specific high-risk factors to consider? Any data?
Steroids in acute COVID-19, we're not talking about hyperinflammation, right? Yeah. So ARDS-like picture, severely deranged inflammatory markers. If you're looking at severe like hyperferritinemias, D-dimers going overboard, you're seeing labs presenting with decreased trend towards thrombocytopenia, leukopenia. You're seeing your cell lines going down. I think we should consider steroids.
Dr. Kohli asks, can MISC exist without clinical features but with acute phase reactants?
With no symptoms at all, sir? I doubt that. We would see something for sure.
Okay.
And then the criteria, the ACR criteria for diagnosis, at least fever, along with one presentation. It's hard to say that you have no fever, you have no symptoms, but just acute phase reactants would go high. Probably a follow-up on those kids, because they would definitely show us some signs over time. Maybe you're seeing the lab parameters going getting abnormal at an earlier stage with the clinical presentations not coming in. But I think a regular follow-up with stringent follow-up, maybe in a day or two, would show us some sign somewhere.
Dr. Arun Wadhwa wants to know how common is in MISC, what is the percentage, and on which date does it present?
How common is it? I'm sorry, how common is?
Is the rash in MISC?
How common is rash in MISC? So around 20% of MISCs are presenting as KD and incomplete KD. So those ones would definitely have a rash. Many times you would see abdominal presentations with a mild rash too. So you would, I don't have exact numbers, but I'm presuming if 20% of KD is presenting, MISC is presenting as KD or incomplete KD, we would say around 20 to 25% of them would have a rash.
On which day?
So within the first 5 days, we should be seeing it if we're looking at the KD presentation.
Okay. Dr. Malhotra, Rajiv Malhotra wants to know how would you differentiate between KD and MISC in cases having immunodeficiency, not manifesting with COVID antibodies?
You mean kids like, so that's a hypothetical question, sir. I mean, if you're looking at things like A-gamma-globuliniemias and hypogamma-globulinias, I don't think at this stage when we are looking at acute presentation with severe disease, I'm sure kids with common variable immunodeficiencies or X-linked hypogamma-globuliniemias where we are not having antibody production, those kids would be severely sick, and you would definitely want to treat them instead of looking for what we have at that time.
I think it's too premature at the moment.
I mean, I don't think we're in a position to even start looking at those. And most of them, if we have them and we have them diagnosed and they're coming up with COVID, they need aggressive treatment. And they may need IVIG on a more regular basis as it is.
What is the minimum age seen in MISC?
3 months has been reported.
3 months. Dr. Badwa wants to know what is persistent. Is there any persistent weight loss as long COVID?
Persistent weight loss. I am not aware on the top of my head, sir, from what I've looked into the post-COVID case reports, but it's a possibility.
Dr. Sabina Bej wants to know, have you seen fibromyalgia post-COVID?
Yes, yes. There are a lot of numbers coming up with fibromyalgia post-COVID.
Dr. Badwa
What age group, ma'am? What age group?
Adolescents. Adolescents.
And what do you treat them with? What do you treat them?
So fibromyalgia again would have a similar, in terms of the treatment, we're looking into regular exercise plans, diet, sleep, physiotherapy to a certain extent. You can try things like hot and cold fermentation. You can try NSAIDs for a short duration, but it's predominantly lifestyle management and changes there and long-term follow-up for those. So at acute stage, probably an NSAID, which would help them elevate this, break the vicious circle, treat them with regular mechanical relieving in terms of hot and cold fermentation, getting into a regular exercise plan, diet, and sleep. So fibromyalgia is more in terms of, if you see fibromyalgia treatment plans, it's going to be something very similar to how we treat those and long-term lifestyle modifications. But just to break the initial vicious cycle of the pain, maybe anti-inflammatory for about 2 to 3 weeks is something that we can see.
Like which anti-inflammatory would be preferred in that?
Things like naproxen, ibuprofen.
Ibuprofen can be used in these.
But again, you make sure that you have all the symptoms of COVID or MISC is gone by, and you're not looking at thrombocytopenia as persisting.
So this would be seen mostly in long COVID, not in MISC. Long COVID.
There are not too many reports now in the pediatric age group with that, but adolescents, yes, we are seeing few coming up. Adults, of course, I think the adult rheumatologists are definitely seeing quite a bit of that.
And they would probably be, I don't know, lifelong or would settle.
Again, there are a lot of factors about fibromyalgia in terms of age, gender, socioeconomic status, all those things. I mean, we could talk about fibromyalgia for hours. So I think it'll all depend on how those factors play a role.
Dr. Manju Sharma wants to know what is the recovery rate in most MISC cases?
Recovery rate. So it also depends on initiation of treatment, how early. So early initiation of treatment has a very good response. The earlier we can get them to a hospital care and treatment has good things, but a delay would definitely be a problem. So early recognition is key, and treatment is key.
Dr. Reja says that we are seeing a lot of patients on teleconsult. And
you can refer that when they're not come in, sir? You're seeing a lot of?
Dr. Sankat Tudeja says that we are seeing a number of cases on teleconsultation and fear that they can miss MISC, those MISC which do not have rash.
So if you're looking, see every kid who has fever, don't stick to rash alone. It is fever with any of the others. So fever with rash, fever with abdominal pain, fever with lymphadenopathy, fever with conjunctivitis, fever with neurological symptoms, subtle neurological symptoms. So any child with fever for more than 3 days, that should raise the alarm, and any of the others. So MISC is not only fever with rash. Let's not stick to KT fever with rash here. A typical KT picture, yes. An incomplete KT picture, yes. Any child with fever lasting for more than 3 days with an exposure, one should start thinking about it.
He wants to know both acute COVID and MISC can present with fever and loose stools. How do you differentiate these on televideo consultation?
You would be treating both of them. Are you going to not be treating them in terms of the lab work you'll have to get done? You'll have to see how the cardiac markers are trending. You'll have to see how the cardiac baseline echo is. Those kids would require full investigation.
There's a question, how often does one get antibodies test done on COVID negative RT-PCR?
How often? So if you're having an history where you see that they're presenting as MISCs, even in mild MISCs, with a history of exposure, you would get an antibody done. You don't need to get repeated antibodies done if you have one positive. You're not following up on the antibody levels. And they are not part of the treatment guidelines. So it's just an evidence that there was exposure to COVID and then there's a hyperinflammatory response. So you're treating that. We don't need trending of antibodies to treat MISCs.
Rajiv Balhotra wants to know cases of fibromyalgia at risk for renal artery stenosis. But here I would like to add that we have talked about a number of systems except for the renal system in MISC.
So there can be renal involvement, there can be hepatic involvement. So there is multi-organ dysfunction happening in case of MISC. Those kids would not only have just hepatic involvement, you see everything in a totality. Fever, organ dysfunction, raised inflammatory markers. You would not see a kid coming with just hepatic dysfunction and fever. He will show you the inflammatory markers also which are involved. So single or multiple organ dysfunction is part of MISC.
Dr. Vada wants to know.
Are we seeing more juvenile? Sorry.
Sadhna?
Okay. I just wanted to ask, since you mentioned multi-organ dysfunction, are we seeing more juvenile diabetes mellitus? Because I have seen a patient of juvenile diabetes mellitus who was exposed to a COVID patient at home about 4 weeks back and then started getting symptomatic. And we did the antibodies and they were strongly positive. So are you seeing more of these patients? Because I did speak to a couple of pediatricians and they said we are seeing more juvenile diabetes mellitus coming in. So could it be some cell antibodies are getting produced?
Hypothetically, it's possible because we're looking at an autoimmune response. Type 1 diabetes again is more of an autoimmune response. So you're talking about antibodies against the islet cells. So considering the fact that there is ongoing autoimmunity, would you say that these kids may have a higher predilection? It's possible.
Can I come in here for a second?
Yes, Dr. Anju, please do.
Yeah, see, this is a very common chicken and egg kind of story because a lot of viral infections were thought to be causing type 1 diabetes. And since we are now very clear that pre-diabetes is a fairly long process, they probably precipitated the DKA rather than cause the diabetes. So you have a small group of people who may have direct insulitis with the viral thing, and you can never prove it because you can't do a pancreatic biopsy. But mostly it is more of a illness, which was the beta cells were dying, and then the infection just precipitated the DKA.
Dr. Dheeraj Avasthi has raised his hand. He probably wants to ask a question. Dr. Avasthi?
Yeah.
Hi, Amieleena, and wonderful presentation. So coming to the question, I have actually written it. The main question is, we have a patient who is on a basis coming with, say, fever. And what day of the illness you will start suspecting that, yes, I am going to send my blood investigations considering this patient is going into MISC. You have a very routine OPD patient. It's very common. You get a fever and the patient you are suspecting, yes, it could be a post-COVID, but patient is reasonably okay. As when Sankalp has raised the question that a patient comes to you, you start symptomatic therapy. You know it's a COVID-19 and you're not going to send blood tests right now. I mean, you're just suspecting it. What day of illness you're going to get a blood test?
Probably I would wait for maybe 3 days and start investigating further.
3 days. I mean, 3 days. Nowadays, we are commonly getting fevers up to 5 days. I mean, 3 days, okay. I mean, the Western standard is saying 3 days. But if you personally ask me and I mean, many of the friends, I mean, you must be seeing many of them. Fourth day, the fever starts coming down slightly, the spikes come down, and by 5th day, we see fever disappearing. So we should have a consensus. We can always discuss.
So those kids, I would not lose to follow. I would see them again, maybe at 7 days, to make sure that we're not missing on anything.
Okay, so you will send the investigations once the fever is more than 5 days. What about steroids on OPD basis? Say the patient is running fever and in the 4th day he's still having high fever and coming to you. You have sent the blood test investigations.
Fever, I would investigate. At 4 days high grade fever, I would investigate before starting.
So the practical problem is on the 4th day, you're sending blood tests, and nowadays labs are really stuck. You have to really wait for blood test and all those things. Would you empirically start steroids?
If you're expecting that
start steroids?
this kid's labs are going to be really bad, he will show you signs. He's not going to be a child walking around with just halka pulka fever. He'll start showing you signs of toxicity. Or there'll be something there that will make you think, okay, this probably needs some more treatment than what we are giving.
A fever, high grade 102,
child
nothing
who
else.
just got fever will be completely normal. Okay, just fever going on, and our labs are going to show us super high inflammatory markers. There has to be a clinical lab correlation, no?
Dr. Vadva supports 5 days. So, I mean, we are seeing many commonly, so many patients have 4-day fever, 5 days, by 5 days they go. The question comes here, should I start steroids on OPD basis or should I wait for the investigation? Sankalp says that we should investigate and then only start steroids. What is your take?
I mean, giving steroids right and center is not right. There has to be and I know that there is a situation right now in Delhi that you can't even get the steroids because everybody is hoarding them and keeping them in there.
Yeah. So what is the purpose of steroids? Basically, we are trying to suppress the inflammation. That is what our aim is. What we are investigating, we are trying to investigate to look for the inflammation. We are trying to look for CRP, ferritin, IL-6. But fever itself is a very important sign of inflammation. So if the fever is persistent, should you really be waiting for the investigations? Your fever is going on high grade, continued. Why can't you start steroids on OPD basis and let the investigations come?
A child who's at high grade fever of 4 days will show you signs of being toxic. He will not be a child who's just walking around normally and we see, oh, when we get the labs there, it's going to be absolutely super high. So that's where your clinical judgment would have to be there,
yeah, absolutely. Right? So we agree that whenever there's inflammation, toxicity means inflammation, no? Significant inflammation to cause. So whenever there's a significant inflammation, we need to suppress the inflammation and probably start steroids after 4th day. Yeah. Okay.
But consider the fact that you're looking at 5 days of high grade fever, you would also consider doing an echo at that time.
Sorry, getting a
echo as well.
Absolutely. That I will never deny.
Dr. Vadva says that aren't these MIC patients more toxic than normal COVID children?
So normal COVID, you mean acute COVID? Yeah, they are. Yeah, they are. Severe abdominal pain not setting down with raised inflammatory markers and fever is an MISC.
Now, Dr. Sankalp says, as of now, I'm managing all fever with loose stools as acute COVID and giving symptomatic treatment only. Do you suggest we should send inflammatory markers and pro-BNP, etc. in all such cases?
You mean RT-PCR positive kids?
No, he's managing probably on teleconsultation. Loose stools as acute COVID.
How are we calling them acute COVID or are we calling MIS? We have to have some support to tell us that it's acute COVID. Do we have an RT-PCR or an AD positive thing that we're calling it acute COVID?
Probably.
Right. If that is the case, then you're treating it as acute COVID and you're not treating it as MISC.
No,
so my question. So you are saying that MISC cannot have a RT-PCR positive?
Less likely. I'm not saying it cannot, but it will also have serology being positive. You could have RT-PCR positive at 4 to 6 weeks also. We know that it is even positive to 8 weeks for people sometimes. That's what has been documented.
So that's the question. So you have a child comes to you with fever and loose stools for 3 days. You get an RT-PCR, it is positive. Now, I don't know whether this is, so I'm sure in the next month, we are going to get a lot of such cases because we'll be stuck whether it is acute COVID or whether it is post-COVID MISC. Because fever, stool, RT-PCR positive can be there.
Did he have prior history or is it the first time that he's there? Is it, so that would help you delineate if this is RT-PCR is something which is lingering along or it is an acute thing. Is there history of fever, COVID positivity in the family members a month ago? That would make you think, okay, is this that? And again, acute diarrhea as presentation is more common in COVID, acute COVID, than MISC.
Okay. So in both the examples, you told that the patient had fever and loose stools, and then we investigated, and it turned out to be
that. See, the first kid had multi-organ involvement. What you
the
are asking?
or involvement was evident only after we investigated. The presentation was fever and loose stool.
He presented with shock. The
Yeah, so
first
I
one
think
presented with
toxicity, as Dr. Vadva said, toxicity, lethargy, these kind of symptoms can help us. No. Yeah.
I think we've lost connection.
No,
Dr. Rajiv says.
No, sir, I got my answer. Hanji, Hanji. There are other questions. I got my answer, sir. Got it.
Right. Okay. Dr. Rajiv Balota says that renal artery stenosis could be a delayed response.
renal artery stenosis could be a delayed response to
Fibromyalgia.
Post-MIC.
You mean vast? I'm not. I don't really get your question, sir. I'm sorry.
Okay. Right. Let's proceed. Can one give short stat dose of the investigations come for steroids? Someone is asking.
Can we give a stat dose of steroids before the investigation? Is it? I mean, is it justified? Again, you'll have to look at the clinical scenario in totality.
Dr. Vadva says most of the tests on day 5 are also normal, but a good baseline on day 5. I think it probably means to what Dr. Avasti was asking. It would become more confusing if they have second time COVID, Dr. Sabina says, which probably is. Now, Dr. Anju Singh wants to probably ask some query. Dr. Anju Singh?
Hello, sir. Sir, actually, the question which was raised that can COVID RT-PCR be positive in the children with MIS-C? Yes, definitely. Studies have showed that around 30% of the cases have shown positive RT-PCR as well. So, although the number is less, but it is, I won't say it is insignificant number to say that it can't be positive in these cases. Secondly, they are various, like MIS-C can be mild, moderate, and severe. So we do not need to throw steroid at every case of MIS-C. The mild MIS-C may not require steroids. So I think regarding the use of steroid, one should be still judicious about it. One need to follow the child clinically regularly, and one has to monitor the features of systemic inflammation. And then Dr. Vadva as pointed out, at day 5 also, we may not get inflammatory markers elevated. So we need to monitor these child before throwing steroid at them.
That is the point, that you need to have more stringent follow-ups. You need to have stringent follow-up with these children, and more frequent stringent follow-ups.
And specifically, it has been seen that children with MIS-C who have KD-like features. So what is the basic mechanism behind KD-like feature? That they have got endothelial cell activation. And because of that endothelial cell activation, there are coronary artery involvement, and we get dilatations of coronary. So if those children who are having this type of picture, then definitely how they their echo comes out to be accordingly, we need to use steroid along with IVIG for these kids.
Dr. Amieleena?
Sorry, sir, I just lost the connection. Yeah.
Oh, no. Are you answering to what Dr. Anju Singh asked?
Anju is talking in general about how we are planning. I didn't get the question. Did you have a question?
No, I was not. I was just sharing my opinion regarding the use of.
Yeah.
So I was just sharing my opinion regarding the use of steroids. Like everybody was talking about using steroid if he has got fever for so much duration. So just an opinion of mine that steroid should not be used like just fever is calming. We need to take everything in totality, the total clinical picture of the child.
See
And
the
at
totality in terms of clinical scenario what we are looking at. It can't be hypothetically been said that, okay, 5 days fever has steroid de do. That is not what we're looking at. And that's what the whole talk is all about. That you will have to see the patient in totality and then judge on what should be the next step.
Rajiv Barotra?
When I asked about fibromyalgia, fibromyalgia is a known cause of renal artery stenosis. So if fibromyalgia happens, renal artery stenosis may happen later and manifest with hypertension. So should we keep a follow-up on that track? Second question is that would you consider MIC in case the COVID antibodies are negative? I mean, you have to have some support to say that it is MISC. I mean, on the basis of history of exposure or having RT-PCR positive earlier on, or having COVID antibodies. If they are not there, would you still consider MIC, or would you still consider that it could be a sepsis? Procalcitonin high, inflammatory markers high. I mean, it could be a sepsis. And in that case, in the case of sepsis, giving all this IVIG and steroids, can they be counterproductive?
There's too much of background noise, sorry.
Yeah, I think Dr. Poonam Devan has mic on.
Sir, Dr. Rajiv, should I talk about this?
Yeah,
I mean, Dr. Rajiv has had a very pertinent point. But sir, we see a lot of renal artery stenosis and intervene them in also. It's a fibromuscular dysplasia, which is actually a very, very important cause of renal artery stenosis, where the muscles become hypertrophy. In post-COVID, these are fibromyalgia. What happens is these are not medial enlargement of the vessels. In fact, this is the hypertrophy. I mean, the such muscles such as these gastrocnemius, all they get very common after viral illness that they become congested, and one of the etiology is the congestion, which
so
causes pain.
So that
it's a different etiology.
So that would be a transient phenomenon.
Yeah, so it's a different pathology, sir. And
okay.
And the second point, your very valid point, because nowadays so much of stress is on multi-mix. It's a we must understand it's a multi-inflammation disorder. That means inflammation which is affecting multiple systems of the body. That is mix. Now, one of the causes of mix, common causes in today's scenario is COVID. But yes, there are other causes such as sepsis which needs to be considered. So if we have a combined thing, I think better Dr. Amieleena would talk about this. But
one thing, see, I'm a neonatologist and I'm not too much involved in MIC business, but it's just a general question that procalcitonin positive is highly predictive of a bacterial infection, is it?
So Amieleena, I think she would be the best person to talk.
Say that there are higher numbers in case of infections. Yeah, I mean bacterial. You can't say definitely bacterial, but yes, infections per se. Yes, you would say procalcitonin is more.
But as far as I know, procalcitonin is more predictive of a bacterial sepsis rather than a viral illness.
Agreed.
So as far as
what we're talking about is the totality in the scenario, considering the fact, and I had a slide which showed you what are the commoner things that we look into this kind of a presentation. We're talking about Kawasaki, we're talking about Kawasaki shock syndrome, we're talking about streptococcal toxic shock syndrome, we're talking about things like MAS, macrophage activation, HLH, we're talking about things like SLE presenting this way, or even small and medium vessel vasculitis presenting this. So this is what
what I mean to say is fever with rash can be a manifestation of a meningococcemia too, and you can have shock. You can have shock and
differentials together for fever and rash.
Exactly. But then giving steroids straight away without having a culture report in hand. Let's say a fever and a rash and a shock. It can be a meningococcemia. I mean, it's a difficult situation. I agree there. And a procalcitonin is high. We may not have coronary abnormalities on echo. Shock is there, rash is there, fever is there, culture report is awaited, and we give steroids. I mean, can they be counterproductive in a severe sepsis?
We will have to look into ways of excluding out an infection before we treating it as MISC. And that's what all our definitions say.
Yeah, I agree. The pros and cons are there. Of course, the risks are involved. Yeah, I agree there.
Sir, as far as procalcitonin is concerned, जहाँ तक मैंने पढ़ा है, it is in acute COVID, all acute COVID will have a raised procalcitonin. All guidelines these days are saying that don't consider positive procalcitonin as an indication for adding antibiotics. As don't start suspecting a superadded bacterial infection when you have a positive procalcitonin. Most severe COVIDs have a positive procalcitonin by themselves, not because of additional bacterial infection. So it is not an
because I may be wrong there. I stand corrected, but earlier on what we read was that procalcitonin is more predictive of a bacterial infection rather than a viral infection.
So we're looking at the inflammatory cascade, which is secondary to any trigger. In generalization, if you're looking at the inflammatory cascade, which could be secondary to any trigger, would result in a higher procalcitonin level.
So it's more of an inflammatory marker rather than a predictive of...
The thing is, we've always tried to do things in the sense that make them into two different categories: infection alag hai, inflammation alag hai. But actually, aisa nahi hota na. They actually, the infections are triggering the inflammatory cascade. So to be able to completely delineate two things and say, okay, this is not inflammation, this is all because of infection, doesn't really exist. So your decision making in terms of treatment further would depend on what you're seeing in the clinical scenario.
There's a lot of overlap there. I agree there. And, IVIG being a very expensive drug. I mean, a child, let's say, who's about 7, 8 years old, would need a lot of dose of IVIG and would manifest an expenditure of close to maybe over ₹1 lakh. So at times, that decision becomes difficult. I agree there.
I hope there are no more questions.
I know it's a topic which is absolutely burning, and we're still all learning on how and what's the presentation, how do we need to move around it. And there are guidelines coming over every few days from the world over. It's an evolving learning process, I guess.
No doubt, no doubt. Thank you, Dr. Amieleena, for a good presentation and the discussion. And it's over to you, Madam President.
So we all know COVID is raging and MISC is bound to follow. Thank you, Dr. Amieleena, for an excellent and useful presentation. And I think this will help us recognize and steer through the problem in the coming days. And we should all, as you mentioned, that most of the kids will get well, but the key is to pick them up early and to have a very high sense of suspicion. So that is what is the learning point from today's topic. And we thank you so much. It was really an excellent presentation, and you took up all the questions very well. Thank you so much. Thank you, Dr. Rajiv, for chairing the session and taking us through all the questions. And we had an excellent question answer session with all the participants, participating very well. We had almost 45 participants, so that is the magnetism of Dr. Amieleena, I think, and we had a good house.
It's absolutely the topic.
So thank you, participants, for joining in, and please do join in next week. We have excellent sessions on COVID coming up. We'll be talking about the perinatal and neonatal management of COVID. We'll be talking about the role of alternate therapies in COVID. We'll be talking about the dietary management of COVID immunity. So we have a lot coming up on COVID next week. So do gear up and join us in large numbers. Good night, everybody. Enjoy dinner.
Thank you.
And see you next week. Bye-bye.
Bye-bye. Thank you.
Good night.